Thank you very much. Many of you may have seen me speak before, probably find it a little odd that I'm speaking about Cushing's disease, since most of the time I'm speaking about kidney disease or particularly lower urinary tract disease. But as an internist, I see everything. I don't just see urinary cases, although they are the ones I like the most. But this is one that today we're going to talk about Cushing's disease, something that I get a lot of consult phone calls about interpreting testing, who we test, when we test, what test to choose, and maybe a little information about some new things that we have available to us. So just a quick conflict of interest statement. Obviously, this is sponsored by Zomedica. Thank you all very much, Zomedica, for allowing me to speak here today. I have spoken in the past for Merck Animal Health and PRN PharmaCal. So just a very quick going over of adrenal physiology. There are three zones in the adrenal gland: the glomerulosa, the fasciculata, and the reticularis. The glomerulosa makes and secretes aldosterone. The fasciculata makes and secretes androgenetic cortisol, as does the reticularis. People sometimes say salt, sugar, sex when they discuss this, because cortisol is more likely to be coming from fasciculata and androgens from the reticularis. So you may remember that from vet school. And then we have the pituitary gland, which has three parts also. The anterior lobe, or pars distalis, which makes growth hormone, ACTH, thyroid stimulating hormone, luteinizing hormone, and follicle stimulating hormone. The pars intermedia, and then the posterior lobe, which is the pars nervosa, which makes antidiuretic hormone and oxytocin. The anterior lobe is the one that we think about when we're talking about Cushing's disease, though, because that's where ACTH is made. So when we think about what the HPA axis looks like, the hypothalamus pituitary adrenal axis, you have the hypothalamus, which releases corticotrophin releasing hormone, or CRH, when there is a stressful event that occurs in the body. CRH then travels to the anterior pituitary and stimulates release of corticotrophin, which is ACTH, and then that travels to the adrenal gland, which then makes aldosterone and cortisol. And your cortisol is circulated through the liver and then has negative feedback effects on both the anterior pituitary and the hypothalamus, as well as the adrenal gland itself. When we think about the pathophysiology of hypercortisolism, so when an animal has a large amount of cortisol, that cortisol normally provides negative feedback, like I said, to the adrenal glands and also to the hypothalamus and the pituitary, and shuts down the secretion of CRF and ACTH. If you have a pituitary microadenoma, so a microscopic tumor within the pituitary that is secreting a lot of ACTH, that's going to put heavy stimulation on the adrenal glands. So the adrenal glands will produce a lot more cortisol. That cortisol is going to then try to have negative feedback onto the pituitary and the hypothalamus. Unfortunately, that microadenoma in the pituitary doesn't care about the feedback. The hypothalamus will come down and reduce the corticotrophin releasing factor, but you are not going to necessarily affect the ACTH and turn that off because it's coming from a tumor. And remember, tumors are like, they just don't care about what other feedback is going on them. And then they're like the honey badger. That's what I was thinking. They're the honey badger. They don't care. So then when you have an adrenal tumor, you have a large amount of cortisol actually being secreted, and that's going to suppress the ACTH and CRF that's coming from the pituitary and the hypothalamus. So whether it's a pituitary or an adrenal source tumor is going to change whether or not there's a large amount of ACTH or a small amount of ACTH. And that would be ideally a great way to test for whether you have a patient who has a pituitary dependent or an adrenal dependent Cushing's. So keep that in mind. We'll talk about that a little bit later. So what does hypercortisolism do to the body? It causes increased protein breakdown and muscle wasting. That's why we get one of the reasons we get our potbelly appearance. Our patients get muscle wasted along their epaxials. It increases fat synthesis, so they put a lot of fat in their abdomen. They get hyperlipidemia and central obesity. And it interferes with antidiuretic hormone, which leads to the PUPD that we see as classic with hypercortisolism or Cushing's disease. It also causes decreased T4, so you can get T4 total T4 suppression. So they can look as though they're hypothyroid, even if they're not. And it increases hepatic glycogen deposition. So their liver actually gets larger, increases their ALP, and you may have a mild ALT increase as well. That hepatomegaly combined with the muscle breakdown of their abdominal muscles leads to that classic potbelly appearance. So when we look at pituitary-dependent hypercortisolism, which is the most common type of hypercortisolism, 75 to 80% of them have an adenoma on the anterior lobe. And that makes sense because that's where ACTH is normally made. And so there's an impaired response to the negative glucocorticoid feedback. And in these cases, you usually, because it is on the pituitary gland and not on the adrenal gland, when we do things like a high-dose dexamethasone suppression test in order to differentiate a patient who has pituitary versus adrenal gland sourcing of their hypercortisolism, these guys actually will suppress. The honey badger don't care, but if you yell loud enough at it, it'll listen, okay? So if you give them a pretty big slug of dexamethasone, that pituitary tumor will actually drop its ACTH secretion a little bit. When you have, so that's 75 to 80% of those. The other type of pituitary-dependent hypercortisolism is in the pars intermedia, and that's 20 to 25% of the patients. And those ones actually don't always suppress with high-dose dexamethasone suppression tests. They test almost like it's an adrenal tumor. So there's a small percentage of pituitary tumors that you're not going to necessarily be able to use classic high dose or low dose and high dose dexamethasone testing to discriminate between whether the source is adrenal or pituitary. They tend to be larger tumors, and they can be very confusing to interpret. But again, we may have some ways to get around that now. The pituitary adenomas can either be small, which we call microadenomas, and those are definitely the most common, or large, which we call macroadenomas. Macroadenoma cases, oftentimes the dogs have additional neurologic changes because they have compression of some of their brain, and they may act like they have a headache or neck pain, and their clinical signs may wax and wane a little bit more than microadenomas. Increased ACTH secretion from these tumors leads to increased secretion of cortisol from the adrenal cortex. And not always, but in many cases, that will lead to bilateral hypertrophy of the adrenal glands. And that's as the same way that if you're going to work your muscles out and lift a lot of weights, your muscles are going to get big. Basically, the ACTH is making these adrenal muscles get really big because they're producing much more cortisol than they normally would. When we think about adrenal tumors, the adrenal-dependent hypercortisolism, usually this is an adenoma, which is a benign, meaning it's not going to be invasive to other tissues, or an adenocarcinoma on one adrenal gland. Occasionally, you will see two adrenal glands involved. That is, has been reported, but most commonly it's one. It is independently secreting cortisol without any influence from ACTH. In this case, because there's large amounts of cortisol that are being secreted and having negative feedback impacts on the hypothalamus and the pituitary, the ACTH levels are actually usually low as compared to the pituitary gland tumors where they're usually very high. Cortisol levels are not suppressed in this case by high-dose dexamethasone. This is the real honey badger, which doesn't listen at all. Even when you yell at it really, really loud with lots and lots of dexamethasone, that adrenal tumor is not going to suppress. In fact, the contralateral adrenal gland may be small because it's got an atrophied cortex, because not only is that adrenal gland producing a lot of cortisol, having a negative feedback on the pituitary and the hypothalamus, it's also telling the other adrenal gland, hey, don't even bother to make any cortisol. I make it plenty for everybody, although it can be normal appearing. So this is just a quick review. We probably already all know this. What do cushingoid dogs look like? They're usually a middle-aged to older dog. It is rare if they're less than 6 years old. It's pretty uncommon. Much more common in small versus large breeds, and it can occur in any breed. We certainly can see it in large breeds as well. We can see it in poodles, dachshunds, terrier breeds, beagles, and German shepherds. Those are some that are commonly cited. And larger breeds actually may be more likely to have adrenal tumors versus pituitary tumors, but pituitary-dependent hypercortisolism is the most common across all breeds. So our clinical signs of hypercortisolism, as we all know, 85% of these cases have PUPD and 90% of them are polyphagic. So the classic polyuria, polydipsia, polyphagic, that's not hopefully diabetic. We can see lethargy, panting, pyoderma, there's lots of skin changes, alopecia, weakness in the muscles, the abdominal enlargement, that classic pot belly, obesity, the thin skin, calcinosis cutis, all those different things. The problem is, though, we're not seeing, these are the textbook signs that everybody told us in school. We're just not seeing as many dogs with these classic signs because we're actually doing a way better job of identifying these cases early. And a lot of that probably has to do with the fact that so many dogs are living indoors, and clients become aware when they start developing PUPD and they have to be let out in the middle of the night. And that's when they come to our doorstep and inquire for, what can we do to help with their polyuria and polydipsia. And so we're not seeing a lot of these really horrible end stage cases like we see the pictures in the textbooks. So we need to have a little better understanding of what they're going to look like when they're more subtle. Usually these dogs are not sick. They are not vomiting. They don't have diarrhea. They definitely eat. They're not coughing or sneezing. They're not in pain. They don't have liver disease or kidney disease other than the elevated ALK Phos and mild elevation in ALT secondary to cortisol. If you see one of these patients, these PUPD patients, that also has one of these other clinical signs, it does lower the index of suspicion of hyperadrenal. Now, can you have an animal that develops a secondary pneumonia because they're immunosuppressed because of their hypercortisolism? Yes, that's possible, but it's not all that likely. And so most of these cases, if they have one of these other sickness problems on their list, is probably not going to be cushingoid. It's not wrong to try and rule it out, but you need to keep looking in other places before we jump onto Cushing's disease. What are the things that we see on our clinical pathology testing? A high ALK Phos, 95% of patients with hypercortisolism will have an elevated alkaline phosphatase. Now, that doesn't mean everybody does, but the vast, vast majority do. Interestingly enough, how high that ALP is does not correlate with how severe the disease is, which is kind of interesting. It's just the animal's individual genetic makeup about how much they react or how much ALP they produce from the cortisol. 85% of them are PUPD and have isostenuria. Half of them have a low T4. Many have a high cholesterol. A few have a low phosphorus. Oftentimes, you'll see a mildly high glucose level, a mildly decreased potassium, and a mildly elevated sodium, sort of the opposite of what you would see with Addison's disease. But they oftentimes have a stress leukogram as well, because cortisol is what leads to a stress leukogram, lymphopenia, mature neutrophilia, that sort of thing. So just to briefly touch on alkaline phosphatase, I actually have a whole lecture I give called Chasing the ALK Phos, because we get a lot of cases referred to us where they're a patient with an elevated alkaline phosphatase and cannot figure out why it's elevated. They've ruled out Cushing's, they've ruled out steroid administration, they're worried about liver disease, and so where do we go now? Alkaline phosphatase catalyzes the hydrolysis of phosphate esters. There are 3 serum isoenzymes in the dog: liver, which oftentimes is induced by cholestasis, the bone, which is induced by osteoblast turnover. So we see it in young growing animals being elevated, and then the corticosteroid induced. Remember, cats do not get the corticosteroid induced ALK Phos. So a cushingoid cat does not necessarily have an elevated ALK Phos. A cortisol-induced alkaline phosphatase elevation is sensitive but not specific, meaning it's very common in dogs who have Cushing's disease or hypercortisolism, but just because the ALK Phos is not elevated, or just because the ALK Phos is elevated, doesn't mean it's Cushing's disease. It can also be elevated by a number of other things. We know that there's at least one major drug that leads to elevation of the ALK Phos. This is actually a not complete list, but close to it, of drugs that we know can do this. Now, many of these drugs we don't really use anymore, like halothane and things like that, but there is one that we still use pretty commonly, and that would be phenobarbital. Don't forget, phenobarbital will actually increase the ALK phosphatase in in dogs. And then we have vascular hepatopathy, which is another cause of alk phos elevation. It's not really well characterized. We don't really understand a lot about it, but we see it in older dogs. So you get vacuolated hepatocytes in these patients when you biopsy them. There doesn't seem to be a lot of functional abnormality associated with it. The liver might be mildly enlarged, but usually not too much. And when they look, this is what a steroid hepatopathy looks like, but the patients don't actually have high levels of cortisol. They actually test negative for Cushing's disease, and there's no evidence of other adrenal illness that's actually leading to this vascular hepatopathy. So sometimes that's what we end up with when we chase the alk phos and are ruling out all the other things that they could have that could lead to elevated alk phos. So what are our testing options for diagnosis of our patients? We can do a urine cortisol creatinine ratio. That is a really good test if you have a fairly low index of suspicion of Cushing's disease and you're trying to rule it out and get it off your list. You have a PUPD dog, you think the dog has something else going on like kidney disease, but you just want to get Cushing's disease off your list. And so that's one. Another is the low-dose dexamethasone suppression test. Then we have ACTH stimulation test and low-dose dex suppression test, urine cortisol creatinine ratios. Once we have diagnosed Cushing's disease and we're trying to determine whether it's adrenal origin or pituitary origin, because adrenal origin potentially can be cured with surgery, we want to do a high-dose dexamethasone suppression test. And this will lead to suppression of pituitary tumors, except those few pars intermedia adenomas. We can use imaging to differentiate between the adrenal and pituitary. You can do an MRI, we can do a CT of the head. We can also do an ultrasound of the adrenal glands and see if they both look big, or if you maybe just have one that looks really big and one that looks really small. Now, again, remember the ACTH level in pituitary dependent hyperdrenic or hypercortisolism, whether it's pars intermedia or not, is going to be high. And with adrenal tumors, it's going to be low because it's being suppressed by all of that cortisol that's being produced. So let's talk a little bit about some of the tests. Urine cortisol creatinine ratios are great to rule out Cushing's disease in a patient you think doesn't have it. So you send your patient home and wait about a week. And what I do is I have them on a day when they have not had any stress for about a week or more. The owners can free catch some urine in a jar. It doesn't have to be refrigerated, doesn't have to be, cystocentesis. They can do a free catch, but we want to do the first morning urine sample after they've had a restful night. And then they bring it in and we check it to see what the urine cortisol and creatinine ratio is. Sensitivity of about 75 to 100% and a specificity of about 22 to 77%. And what this means is that if they have a normal UCCR, they're very unlikely to have Cushing's disease. But if they have an elevated UCCR, it may be stress from some other reason, which is part of the reason why we can't really take this in the hospital. The stress of putting him in the car, going somewhere new, sitting in the waiting room with all the other dogs barking, that is enough to put cortisol into the urine and make this test difficult to interpret. Now, ACTH stimulation tests have about an equal sensitivity and specificity of 85%. So essentially what we're doing is we are stimulating the adrenal glands to produce cortisol. It can be used to diagnose iatrogenic Cushing syndrome as well, in which case you get a flat response. So that's in a patient who looks Cushionoid because they're receiving a lot of steroids. And so they look Cushionoid, but their adrenal glands can't respond because all the exogenous steroids they're getting have suppressed their adrenal gland function. With adrenal tumors, we may have some variable test results. It's not a great test for adrenal tumors because half of them might be resistant to the ACTH stimulation because they don't have normal receptors on them like a normal adrenal tissue would. Low-dose dex suppression tests have a sensitivity of about 95% and a specificity of about 73%. So what this means is that it's going to catch most Cushionoid patients, but there will be a few false positives. If suppression occurs at 4 hours, but escapes at 8 hours, then pituitary-dependent hyperadrenal is likely. So we take a 0 and a 4 and an 8-hour test in the dog and look and see where the numbers come out for the cortisol level. If it's flat across the top and there's no suppression, then it is either pituitary or adrenal dependent, and we need an additional test to tease out that pituitary versus adrenal, and that's the high-dose DEX test that we do. So the high-dose DEX suppression test essentially is going to try and tease out pituitary versus adrenal. Adrenal tumors are independent of glucocorticoid suppression. They completely ignore it. They're the ultimate honey badger. And in a study that Dr. Feldman did out of Davis in 1996, he showed that out of 178 dogs, he had 148 with pituitary-dependent hypercortisolism and 30 with adrenal-dependent. Almost all of the adrenal ones did not suppress. And most of the pituitary ones did suppress. This is where we get our sensitivity and specificity numbers. It is not good for diagnosing hyperadrenal or hypercortisolism. It is made to differentiate between pituitary and adrenal gland. Do not use the high dose to diagnose adrenal disease or pituitary disease. Use the low dose to do that. There's some other tests that can be done out there that are sort of gaining in popularity. We've got the plasma ACTH level, which would be great because it will differentiate between the adrenal tumor and the pituitary tumor really nicely. Again, it's elevated with pituitary tumors and it's suppressed with adrenal tumors. The problem is it rapidly degrades in vitro, so it's very difficult to get accurate measurements, and it generally needs to be sent to an alternative lab like at Tennessee or Colorado. If you are going to send it out, you have to check with the lab regarding shipping and handling because there are very specific guidelines. And some places even ask that you send a sample from a totally normal animal along with it, so they'll know whether or not there's been any degradation. Now, however, we have the potential to perform endogenous ACTHs in-house with the TRUFORMA diagnostic platform. It eliminates the shipping and handling concerns. We don't have to put a preservative into it, that sort of thing, but we'll talk about that in a little bit. So how are you going to choose which test to use? I generally base it on my index of suspicion. What is the signalment of the dog? What are the clinical signs the dog is exhibiting? Is imaging giving me any idea based on what the adrenals look like? Are they both a little bit plump? Is one plumper than the other? That sort of thing. And then looking at the blood work, how much do I think that these animals' PUPD and polyphagia are secondary to Cushing's disease? And also, what is the availability of DexSP and Cortisol? Most everybody has DexSP in their hospital. It is a very common drug. It's inexpensive. Lots of people have it. Cortisol, unfortunately, not everybody has unless they see a lot of Cushingoid patients. And it can be expensive. Generally, we recommend aliquoting it out to in 5 to 15 microgram microgram aliquots, and it can be frozen for several years. So that's a really good way to preserve it if you don't have a lot of use for it. And then what is the convenience that you have? Because although cortisone's expensive, it's a 1-hour test. So it's very easy to do the test and let the client go home and get your patient out of there and move on with your day. The high dose and low dose dexamethasone suppression tests are 8-hour tests. That means the animal has to be dropped off first thing in the morning. You start the test right then, and they get a 4-hour and 8-hour sample, and the patient has been in the hospital the entire day, and it's sort of, taking up cage space and that sort of thing. So like I mentioned, the index of suspicion, the more severe, if the animal has a non-adrenal illness, the more severe the non-adrenal illness is in an animal that looks like it has hypercortisolism, but doesn't actually have it, the higher the likelihood of a positive result on testing. So if you have a very sick animal that you're concerned about having hypercortisolism, but it actually doesn't, you have a higher risk of false positives. And that's because how sick they are actually determines the amount of cortisol they're secreting. If you have a patient who's not actually all that sick, but maybe just a little PUPD, and they don't have Cushing's disease, but you're worried about it, you're more likely to get true positives and not false positives. So this is just a quick graph of sort of when you think about using the various testing. So if you have a low suspicion of likelihood of having of the patient having Cushing's disease, you want to probably use a urine cortisol creatinine ratio. They're so easy, they're not very expensive, and the owners are happy to obtain them for you. If you have a very high suspicion, using a low-dose DEX test is probably your first option if you have the time. And if you don't, and you do have cortisol, then doing an ACTH dome would be useful. And then when we differentiate between pituitary-dependent hypercortisolism and the adrenal tumor, that's when we're going to use our high-dose dexamethasone test. We do have some indicators from the low-dose DEX test about whether or not they are high or whether or not they are pituitary or adrenal. So that's something that I'm going to go over in just a moment. And then the ACTH level would also really help us differentiate between those two types of sources of hypercortisolism. So we're going to go through a few cases here. So I'm going to give you guys a moment. I'm going to pause each time so you guys have a chance to think about what you think the result is. So this is a 11-year-old female spayed miniature poodle who's been PUPD for about a month. And so we performed a low-dose dexamethasone suppression test on it. So this is 0 hour, 4.3. This is the 4-hour measurement at 2, and the 8-hour measurement at 3.5. Now, suppression has a specific definition. Suppression of the cortisol level means either more than 50% drop from baseline or dropping below 1. It's not just dropping below 1. It also means more than 50% drop from baseline. So I'm going to give you guys just a moment to think about this. All right, so in case 1, we start out with 4.3, and then we drop to 2. That is more than a 50% drop. Oops, excuse me. That is more than a 52% or 50% drop in baseline. So at 4 hours, we suppressed, but then we lost our suppression at 8 hours. So this animal has Cushing's disease. The other thing this animal has is the kind of weenie honey badger, right? So the pituitary gland said, I don't care at 4 hours, but 8 hours was like, yeah, I guess well, they said, I do care about you giving me dexamethasone at 4 hours, but only responded to the suppression for a short period of time and then bounced back up again. So this is a pituitary dependent hypercortisolism. If you see this sort of chevron shape, that is pituitary dependent, as long as the drop is more than 50% of baseline or it's below 1. Let's do another one. So case number 2, this is an 8-year-old male castrated Yorkie with polyphagia and some hair loss. So we're going to do a low-dose dex suppression test. At 0 hour, it's 3.5. At 4 hours, it's 0.8. And at 2 hours, or at 8 hours, it's 2. So what do you all think? Well, we started out with 3.5. We have suppression to 0.8. This is more than 50% drop. And then we pop back up to 2, and it's also below 1. So this animal suppressed at 4 hours, and if had it stayed down, we would have said this animal does not have Cushing's disease. But the fact that it popped back up tells me that this dog most likely has Cushing's disease, and it's probably pituitary. Remember, there are exceptions to every rule, but it's most likely pituitary. This is a 10-year-old female spayed doodle. This dog has an ALK phos of 700. And so we perform a low-dose dexamethasone suppression test. 0 hours, 2.5. 4 hours, 0.5. 8 hours, 0.4. So first question, does this animal have Cushing's? And if yes, Can you tell whether it's adrenal or pituitary in origin? So this animal actually does not have Cushing's disease. We suppressed below 1 and more than 50% at both 4 and 8 hours. Okay, let's see. There we go. Case 5. Okay, this is a 12-year-old Labrador with PUPD and polyphagia. Although, how do you tell if a Labrador has polyphagia? They kind of all do naturally, right? Anyway, a 12-year-old Labrador with PUPD and polyphagia, positive on ACTH stim. So we do an ACTH stim test on this dog, and it comes up positive. So that animal has Cushing's. We know that. Now what we're trying to figure out is, does the animal have pituitary dependent or adrenal dependent? It is a large breed dog, so we worry it could have adrenal dependent. And if it is adrenal dependent, it can be surgically corrected, and the animal doesn't necessarily have to be on medication for the rest of its life. Give you guys a moment to think about this. So your baseline is 5 at 0 hour. At 4 hours, we're 4.5, so we haven't dropped below 1 or 50% of baseline. And then at 8 hours, we're at 4. So we basically did not drop in this one. So that means that this animal likely has an adrenal tumor or a pars intermedia. So it could be a pituitary tumor. So this is where we want to do a really good evaluation of the adrenal glands, either by CT or ultrasound, and potentially even imaging the brain looking for a pars intermedia tumor. Case 6, now this is different. This is an ACTH stimulation test. So it's a 15-year-old female spayed Schnauzer with PUPD and an alk phos of 690. We do an ACTH stim test, so it's 0 and 1 hours. So our initial cortisol is 6.8, and our post is 9. So do you think this animal has hypercortisolism or not? Probably not. Usually dogs that have hypercortisolism will stim above 18. So this dog stimmed a little, but not very much. And the idea is that those adrenal glands have been stimulated by ACTH so much from an adrenal tumor that they've built up a whole lot of cortisol. And so, or even if they have an adrenal tumor, they've built up a whole lot of cortisol. And if they get stimulated to release it, they'll release a whole bunch all at once. So that's why we feel like there's really going to be this huge increase in the cortisol level for an ACTH stim that's positive for Cushing's disease. So this case actually probably does not have Cushing's disease. Let's see here. And then we have case 7. So case 7 is a 15-year-old Bichon cross with thin skin and an alk phos of 980. And so this dog, we are going to do an ACTH stimulation test on. So our baseline is 6.8, and our post at 1 hour is 20. So what do you guys all think? So this dog most likely has Cushing's disease. This is a significant increase in the Cushing's or in the cortisol level, and this indicates that there's a lot of cortisol around in those adrenal glands, whether from a tumor or from them being stimulated by ACTH chronically coming from a pituitary tumor. So let's say we get our diagnosis of whether or not the patient is Cushingoid, but we aren't sure if they have adrenal dependent or pituitary dependent. What can we do? We can look at for masses on the adrenal glands. We can occasionally see a mass on both adrenals. Oftentimes with that case, one of the masses is not doing anything. It's just sitting there. It's not secreting anything, and it's not invading into anything. And the other one is a problem. And it's very difficult to determine which one's doing which. So we have patients we've sent to surgery that actually took both adrenal glands, and we basically made them Addisonian, and then they just lived being supplemented with prednisone and DOCP for the rest of their lives. You can have a situation where the adrenal glands look normal, but the ACTH stim or the low-dose dex indicates the patient has Cushing's. But again, you're not sure if it's adrenal or pituitary based. So it's challenging, especially if we do a high-dose dex and it's flat across, because so if it dips and stays down, high dose, or it dips and goes back up, that is a pituitary tumor. If it stays flat across the top for the high dose, it is either adrenal or it is pituitary. It really could be either one. So is there any other way we can find to get a better idea of what we're dealing with? As I mentioned before, the ACTH level would be great, because if you have an adrenal tumor, the ACTH level is very low. If you have a pituitary tumor, the ACTH level is likely to be high. Again, normally we have corticotropin releasing hormone, which then stimulates ACTH release, which then leads to cortisol, which has negative feedback on the adrenal glands, as well as negative feedback to the hypothalamus and also to the pituitary. If you have a patient that has an adrenal tumor, you're going to have tons of cortisol coming from that adrenal tumor and negative feedback onto both the pituitary and the hypothalamus, which will vastly suppress the level of ACTH release. So it will be low. In a patient with a high ACTH and a pituitary tumor, you're going to get a lot of cortisol, but that cortisol is going to cause local suppression of the adrenal glands, suppression of the hypothalamus. It's going to try to suppress the pituitary gland from producing ACTH, but it's not going to succeed because that's a tumor. And so that's going to keep secreting ACTH, and that's when you get your very high level of ACTH. So why don't we already measure ACTH? Because you would think that it would save all of everything we do by just doing one test, right? It would save us the dexamethasone test, the ACTH stim test. It just would make life easier if we could just measure it. Unfortunately, endogenous ACTH is a very labile hormone. You can see by this data from Zomedica that endogenous ACTH concentrations with time at room temperature will sometimes even start lower and then they start degrading. And same thing with one that's very high. You're going to have the level of ACTH start to deteriorate after about 2 hours. And unfortunately, that means that even if you keep it on ice or ship it on dry ice, you still run the risk of it degrading during the process of shipping it overnight to the lab. The great thing now is that there's a point of care test available. It's a very small, compact, easy to use machine. It's very self-evident how to work it. And this is the new TRUFORMA eACTH testing. It is the same equipment that you can use to test for cortisol levels, test for thyroid levels, for T4 and TSH as well. So we can use it for all different things. We use it for TSH a lot in our I-131 cats, but you can definitely differentiate pituitary versus adrenal with looking at the ACTH level with this, because it's cage side, and so there isn't that degrading. You're basically drawing the blood, spinning it down, and sticking it right on the cartridge, and it's super easy to use, and that's going to give you your information as to whether or not the dog is more likely to have adrenal dependent or pituitary dependent Cushing's disease. And with that, I'd like to thank all of you and offer up questions if anybody would like to expound upon their thoughts. I'm happy to go back over some of the charts, anything like that. So thank you all for listening.